Hi, welcome to our webinar about methadone formulations, clinical pearls, and patient experience. I am Dr. Christy Sutherland. I'm a family doctor and addiction medicine specialist. I work in Vancouver's downtown east side at the Portland Hotel Society and as a physician education lead here at the BCCSU.
And I'm Garth Mullins. I'm part of the BC Association of People on Methadone and host of the Crackdown podcast, and also a methadone patient myself.
So I remember this well. In February 2014, BC removed the generic compounded methadone from the provincial formulary and replaced it with methadose. So this was a big deal. We had 17,000 people on methadone at the time who overnight switched the brand that they were taking for their medication that they were on every day that we know is a life-saving medication. So it was 10 times the concentration, a different company that made it, and a different taste. It was cherry. You must remember that well, Garth.
Oh yeah, this came as a shock to a lot of people. I heard about it because being in groups like the BC Association of People on Methadone, we kind of watch these things. But I think most people went to their pharmacy one day and they're just like, "What's this now?" And pretty quickly, I think in the next few days after that, whenever someone got switched in that month of February or early March of 2014. People started feeling the symptoms of withdrawal, so dope sickness. Lots and lots of people were coming to us and saying that, and lots of people started to top up with other opioids from the street.
Oh, I remember exactly the same thing. So this change was because, we were told it was because that methadose did not require compounding. So the previous compounded methadone came in a powder and was mixed with Tang to be diluted and prepared at each individual pharmacy. And the new formulation didn't need to be stored in the fridge. So this was thought to decrease the potential for pharmacy error in dosing and to decrease diversion. So there were thoughts that some pharmacies were watering down the medication. But there was no consultation with people on the methadone program. It just was a sort of unilateral decision with a massive switch that didn't involve the people on the medication. So what evidence did they use for transitioning formulations? So there was this small 1999 study that was a double-blind, three-way crossover trial that compared methadone pharmacodynamics among a group of 18 people who were switched between methadose tablets, methadose liquid, and methadone discants. They measured plasma levels, and there was no difference between these three groups across the three medications. This study was fully funded by the pharmaceutical company that manufactures methadose.
And in our attempts to reverse the switch, or at least get the option of the compounded methadone back, this study was constantly quoted to us as being an authoritative source. And once I looked into it, you could see there's 18 people and actually no equivalent comparison of how people did switching from compounded methadone that we have to the methadose formulation. Its use diminished, and then we actually went and talked this year to Gurevich himself on the podcast. You can listen on episode 2. And even Gurevich, the author of the study, is a little leery of how it was used.
So what happened after this transition? So I feel all of my patients came in and they would say that they felt terrible, basically. They would say this doesn't have legs, that it would wear off more quickly, so they would wake up in the morning in withdrawal. So people who had been stable on a stable dose, like 100 milligrams, for many years, suddenly that 100 milligrams wasn't holding them for 24 hours and they had reemergence of cravings and then relapse. More pain, malaise, nausea, and then having to top up as their methadose didn't meet their opiate need.
Yeah, this is the same thing we saw at the BC Association of People on Methadone. And as 2014 wore on, this is when fentanyl was really hitting the drug supply too. So people were topping up off the drug supply that was much more dangerous than it had been in just a few years ago. So it was a perfect storm, and we certainly started losing members this way. I don't even know how many, but people who were on our board, treasurer died, our president, Cherise Kiwatin, died this February. And she was probably in withdrawal and dope sick a few hours or more of every day, or almost every day, between 2014 and 2019. And that's a form of torture, I would think. It's absolutely terrible.
Oh, totally. I think nausea is one of the worst things in terms of quality of life that people live with. Because we know that people stop medications because of nausea as a side effect. It's just so uncomfortable. And to combine that with pain and malaise, and then having to turn back to the street to figure out how you're going to get money to get drugs, and then having this shift in our illicit market to fentanyl is just, I mean, the risk is huge.
I think there's one message that prescribers could take away from this is if a patient is experiencing withdrawal in the context of an overdose crisis, it's absolutely deadly.
Yeah.
And that's where you take the great measures. Withdrawal isn't punishment for being a drug user. Withdrawal is something that requires medical intervention quick.
Yeah, I totally agree. And as a physician, I know when I was learning about opioids, you know, we used to say that opiate withdrawal doesn't kill anyone. Sort of like alcohol withdrawal, you can die from. But I think we need to sort of re-examine that sort of old medical pearl, because I think it can kill people in the acute phase in terms of like electrolyte imbalances and dehydration and vomiting. But actually the death from withdrawal is in the days or weeks or months after the prolonged withdrawal is going on, and then the person uses illicit drugs and has an unintentional overdose.
Yeah, so it'll kill you slow or it'll kill you fast,
yeah.
But it'll kill you.
Yeah, so we can no longer sort of have that old medical pearl that opiate withdrawal doesn't kill you.
Certainly my doctor told me that.
Yeah. And yeah, as Garth said, like the timing couldn't have been worse in terms of this shift in our illicit market. So what happened after the transition? So for me, I tried splitting the dose of for my patients or to increase their dose. But we need to remember that increasing a dose will increase the peak plasma concentration, but not to prolong the half-life. So you're just sort of making people more sedated at the 4-hour mark, the peak of methadone, but still at 6 a.m. the next morning, they're waking up in withdrawal. I found split doses marginally helpful for people, but it's a lot to go from a once a day medication to a twice-a-day medication. You're doubling the sort of pill burden for that person. So we know that medication transitions can have a pronounced biopsychosocial impact on patients and on communities. So in the UK, they changed the methadone formulation in 1992, and this was correlated with an increase of non-prescription opioids, decline in social stability, and an increase in pharmacy break-ins. So no surprise. So we have 3 studies that have been published in BC that have concluded the formulation switch has had significant adverse impacts on patients who are on methadone. So this one, Patient Perspectives of Methadone Formulation Change in BC, Outcomes of a Provincial Survey, showed that 56% reported feeling worse or more dose-sick, 50% took additional opioids, and people who reported feeling worse or more dose-sick were almost 9 times more likely to take additional opiates compared to those who did not. For me, I feel those numbers are low, actually. Like in my patient population in the downtown east side, I felt that everyone felt worse. What do you think, Garth?
Yeah, I don't know. I've never really met people who said methadose is great. I'm doing good.
Yeah, I have maybe 1 or 2 people in my 600 patients.
Yeah.
So this is an interesting one because it's looking at specifically HIV-related outcomes, an interrupted time series analysis. So for people living with HIV on methadone, with this formulation change, 11.5% returned to heroin injection, and there was a 15.9% drop in optimal HIV adherence immediately after the switch. So this has negative impacts for those patients because they would have maybe an increase in their viral load and a decrease in their CD4. But it also has negative implications when we look at public health in terms of that we want everyone optimally treated for their HIV because we know that they can't seroconvert someone else. So that when we think from a public health perspective with HIV, that this methadone formulation had made things worse for these individuals and also had a negative impact on public health. And in this study by Ryan McNeil et al., 50% of study participants experienced heightened withdrawal symptoms about 14 to 16 hours after ingestion of methadone. So this is a drug that's supposed to have a 24-hour half-life. And so only lasting 14 to 16 hours is not a great outcome. And that it had a disruption in treatment engagement, which I think makes sense. If you're giving someone something that is just not working for them, why would they keep coming back to you to continue to take it?
Yeah, methadone has one job. And if it's not doing that, what's the point?
Yeah. So why do people feel uncomfortable? And the answer is we don't really know. Let me take you back to undergrad. Methadone is a chiral molecule. So just like your hands, they are a mirror image of each other, but you can't superimpose them. So even though they are identical, they actually, you can't overlap your hands on top of each other. So many drugs are chiral, and they have what's called a racemic mixture. In some drugs, both enantiomers are active, and some drugs just one, and some drugs have an inactive enantiomer. So we think that different formulations of methadone may have different ratios of these isomers. And so even though the plasma concentration is normal, because I remember after this switch, I started doing peak and troughs of methadone for my patients, and it was normal. So even though that plasma concentration is normal, so even at the trough of that drug, when someone is sitting in front of you in withdrawal, the trough can have a normal concentration, but it's what that enantiomer is doing on the receptor in their brain that is not enough for them.
So the methadose is in your blood, but not in your brain as much.
Yeah, it's the ratio of the active versus inactive. Okay, so let's talk about how things have been going with the new options. So this is a Canadian Press article because I mean, it just went so badly. I think it really is an example of when people who use drugs are excluded from the table, when policy changes happen, and that I can't think of any other group who as a whole would be just saying over and over for 5 years, we feel terrible. And to have such a slow response, I mean, it's incredibly frustrating. And so it's critical for our patients to have choice, to be able to be on the medication that serves them best.
What you see here is the editorial board of the Crackdown podcast. We're all drug users. We make this radio show together, and a couple of the episodes detail our campaign and our struggle to get methadone options back. A struggle which we don't think we've won yet, and a struggle which is going to include changing the way policy is made so that this sort of thing never happens again. We're sitting here in the boardroom of the Vancouver Area Network of Drug Users. A lot of these people are also on the British Columbia Association of People on Methadone. And this is what makes the difference between good policy and policy that misses the mark or has unintended bad consequences. That difference is organized drug users. We've actually been able to work alongside of folks like Christy, and that's really helping things out. So please give people the choice as much as you can. The reason why so many of us have such miserable lives is because of the lack of self-determination. So we often wind up with drug habits to begin with because we have never had the agency to make moves the way we want to in our lives. So treatment that also denies us that agency is just going to compound the problem. So give us a little slack and you'll see good stuff.
Yeah, I think as a clinician, like your days are just more pleasant when you have happy patients who are doing well. Like I'm happy also to see the unhappy patients and have them, talk about their challenges and things like that. But like what a joy to be able to provide something that someone asks for, that they say benefits them, and then they come back to see you and follow up and they're like, Doc, I feel so much better. And you're like, no, I'm so glad. So I would just encourage clinicians to use these tools that we newly have back in our toolkit to offer patients some options.
Think about the last 5 years, and as in 2014, the methadone got weaker, or at least it felt like it for a lot of us, the drugs got stronger, and that gap opened up. And that gap is still there, and so the new methadone or the returning methadone options that we have might close that gap for some of us, but it's going to remain, so we're going to need to be looking at those other options too. So if people don't do well on the compound methadone, it's not on you, it's not on it's not on the methadone itself. It's the fact that things never stand still under prohibition. The drugs get stronger and stronger and stronger, and so we have to keep bringing up options, not taking them off the table.
Yeah, totally. And I think it's interesting, that's such a good point, in that the context has changed. So when we apply research, we're applying it from a different time that it's from a heroin market. And so when we think about our dosing schedules and our titration schedules, that the research to support those was done in a different context.